Hi everyone, welcome to another question and answer solve. This is the physiology portion. A 28 years old man undergoes an ileocecal resection to treat the terminal ileal Crohn's disease. Post-operatively, he attended the clinic and complains of diarrhea. His CRP is within normal limits and small bowel enterocytosis show no focal changes. Which of the following intervention is most likely to beneficial? So in this question, the patient undergone ileocecal resection for treat of the Crohn's disease. But postoperatively, he complains diarrhea, but CRP within normal limit. CRP within normal limit, that means there is no fissure of the Crohn's disease now. And small bowel enterocytosis. So we have to find out uh, what drug can be given. Here the options. Options are 5-ASA drug, azathioprine, pulse methylprednisolone, infliximab oral polystyrene. So we have to find out one of the option which can be give the patient and benefits of the patient. So important one, ileocecal resection. Second one, diarrhea. Then CRP, which is normal. So CRP normal, that means treated Crohn's disease is now within normal limit. So first of all, let's see about the ileum or details about the ileum. This is the anatomical review of the ileum. The terminal ileum, it comprises about 20% of the total ileum. That means ileum, it is a long structure and it is 20%. That means the terminal 20% is known as the terminal ileum. So terminal ileum is not a smaller space, it is relatively a large area. Then and has diameter that the similar that of the jejunum, typically 2 centimeter at the ileocecal junction. It is true. The ileum attached to the abdominal wall by the mesentery and contain more fats and lymphatics than that of the jejunum. So this point is very important. The ileocecal infection or ileal infection mostly occur in the ileocecal area or in the terminal ileum because they contains more lymphatic nodule, and this lymphatic nodule is directly related to the defense mechanism. So any organism enters our body or any inflammation, usually it is wrapped around this terminal ileum. So when the terminal ileum fails to resolve this, the disease is primarily located in this area. Blood supply of the ileum, it is from the superior mesenteric artery. This point is very important. The ileum, it gets whole of its blood supply from the superior mesenteric artery. They from the vascular arcade to supplies, and all of the ileum contains paired spaces aggregation of the lymphoid follicle. So this point is very important regarding the ileum. And the most of the infection, it occurs due to this ter terminal ileum lymphoid tissue, because lymphoid tissue are related to the defense of our body. And during defense, when the terminal ileum fails, then the disease stays in the terminal ileum and then it dissociates in the other area. The main function of the terminal ileum is absorption of the vitamin B12 and the bile salt. So when we at the ileocecal junction or terminal ileum, the vitamin B12 absorption and bile salt absorption will be hampered. And in this condition, neuroendocrine cell or all of the ileum base secrete hormone that will also be lost. And in surgical patient, resection of the terminal ileum is a common procedure for the condition as the terminal ileal Crohn's disease and other surgical emergencies. And significant portion of the ileum is removed during this procedure, and for this patient risk of increased bile salt metabolism or increased risk of bile salt metabolism, or also there is reduced vitamin B12. And when bile salt uh, present in the GIT not absorbed in the terminal ileum, it causes bile salt diarrhea and increase the risk also the gallstone, because we know the bile salt, it dissolve the fat. So when fat is not dissolved, it uh, sediment, and with the calcium and other ion, they form different type of the stone. And the lack of the vitamin B12 may predispose to macrocytic anemia. So two important diseases develop during the for the resection of the terminal ileum. One is the bile salt diarrhea, increased risk of the gallstone, and macrocytic anemia. And in this condition, high output diarrhea may develop. And this most causes malabsorption of the bile salt, and this bile salt present within the gastrointestinal system, and the bile salt is very toxic for our body, so they causes irritation, inflammation in the gastrointestinal tract, and causes diarrhea. The administration of the cholestyramine, which is a bile salt binding agent, will counter this. And malabsorption of the bile salt is a common cause of diarrhea following the ileal resection. So malabsorption may mostly occur due to terminal ileum resection. For this ileum resection, the intrahepatic circulation lost, and the bile cannot ex uh, exit the gastrointestinal tract, and it causes diarrhea. A normal bowel study and CRP effectively exclude active Crohn's disease. In this patient, the CRP is normal. That means there is no Crohn's disease now, and therefore immunomodulator drug are not appropriate in this case. So here we can see we can give the oral cholestyramine. Why we can give the oral cholestyramine? The cholestyramine it adverse the bile salt, that means it hampers the bile salt action, that means the bile salt cannot irritate the gastrointestinal tract, so there is no diarrhea. So again here we can see the ileocecal resection, and for this ileocecal resection two important diseases develop. One is there is decreased absorption of the vitamin B12, and another is the bile salt not absorbed, and as the bile salt not absorbed it causes diarrhea. On the other hand, bile salt lack in the blood, it finally causes gallstone. And the CRP, it is within normal limit, that means there is no active inflammation like Crohn's disease. So our answer is the oral cholestyramine. Other options such as the infliximab, which is the modulating drug, it is usually not given after treatment of the Crohn's disease. And methylprednisolone, as there is no inflammation, so steroid have no effect or very little effect in this condition. Azathioprine and 5-acid drug, they usually not applicable in this condition because our pathology due to bile salt. So we have to remove the bile salt, or we have to trap the bile salt by the oral cholestyramine. So this is all about the today's question. That means following a surgery, what will happen in case of Crohn's disease. So we have to become more cautious after resection of bile salt for treatment of this patient. Thank you all.